So hello everyone and welcome this afternoon to another Lymphoma Australia patient educational webinar. I'm Lisa, one of the nurses at Lymphoma Australia and the host for this afternoon. I'd like to begin by acknowledging the traditional owners of the land. I'd also like to pay my respects to elders past, present and emerging. So let's start with some quick housekeeping. If you have any questions throughout the webinar, put them into the Q&A function at the bottom of your screen. We'll have a small amount of time at the end to answer some of them. There is also a chat function, but this won't be monitored for questions. So if you'd like to use the Q&A section, that would be best. If you miss anything today, please don't stress. The webinar will be uploaded to YouTube and Spotify within the next few days, and the link will also be sent to you separately. We have been working on all of our educational webinars at the moment, and they can all be found at the events calendar on the website. Next month, we have a Hodgkin's lymphoma one, and then supporting families part 1, 2, and 3. So talking about working with lymphoma, how to tell young children, those types of things. But if there is something specific you would like us to organise, please reach out to us and we will try to organise that in the near future. And for anyone who isn't aware, we hold regular online support groups via Zoom. Our next one, specifically for those currently in remission, is in July. And then we do have an in-person one in Melbourne at the end of July. So again, head to the events calendar. I'll pop that link into the chat a little later. There is a quick survey at the end of the webinar, and I'll pop it up when it's finished. If you could just fill that out really quickly, it also helps just sort of us plan around what type of things you guys are looking for. Anyway, on to today's webinar, which is the last in our Adolescent and Young Adults mini-series, or for those under 40. Today's about long-term follow-up and survivorship with Associate Professor Kylie Mason. Associate Professor Kylie Mason is a clinical haematologist at Royal Melbourne Hospital. She leads the late effects and survivorship stream within the Victorian Comprehensive Cancer Centre and has an interest in adolescent and young adult haematology with an honorary appointment at the On Track Youth Cancer Service. So thank you so much, Kylie, for joining us today. I know that everyone is very interested to hear what you have to say.
Thanks very much, Lisa, and thank you for the introduction. I'll just share a PowerPoint and please let me know if that's not coming up correctly.
That's perfect.
Looks good.
Very good.
Fantastic.
Yep, great. Very much. Thank you. Go for it.
And yeah, it's just a reminder, please put the questions in the Q&A, as Lisa said. I'm more than happy to answer them, and I'll try to leave plenty of time at the end to do just that. Late effects and survivorship are super important, and even more so in the younger patients, either patients who are adolescents now who were treated when they were children, patients who are diagnosed when they're adolescents, or diagnosed as young adults. And it's super important, not only because people have longer to live, and hopefully much longer to live than someone who was diagnosed inevitably in their 60s or 70s, just on average. But it does mean that it does put adolescents and young adults at a greater risk of long-term side effects, because there is a longer time in which to attain these side effects. They're sometimes confusing and difficult to understand. And what's really important is a little bit of knowledge can really help young people and not only patients but family members navigate the system and take charge and control of their own health with a passport of understanding of their disease and their risks of treatment. So why talk about late effects? So who are we talking about? What are the late effects and what does it mean? So morbidity is people feeling sick, and mortality is people dying. And so do late effects cause people to be sick? Do they cause people to die early? And often after someone has survived cancer and they've got to that sort of 5-year mark where everything's in the all clear for many cancers, people wonder, is this it? Or what's in store in the future? How do we define late effects? What is a late effect? How are they caused? Chemotherapy, radiotherapy? And how do we approach late effects? How do we think about late effects? How do we look at care plans? How do we look at reviewing these? And particularly, what's the risk of cancers in the future? And then lastly, just want to touch on what every survivor should know going forward. So why do we talk about late effects? So late effects, what are they? They're any effect that occurs chronic or late. It's an adverse medical or psychosocial outcome, complication or disability that persists or develops from related to the original diagnosis of cancer or the related treatment. So late effects are not always things like another tumor or a lung condition. They can be things along the lines of a reduced education from, missing school. They can be things like not being able to get insurance cover because you've had a cancer, for example. We tend to think of those slightly differently, but they really are late effects of cancer treatments or having had cancer. The good news is that survival rates for cancer are very high these days. You're greater than 80% for children, greater than 60% for adults. And in the USA at the moment, there are over 10 million cancer survivors. And we know that around 1 in 640 people is a survivor of childhood or adolescent young adult cancer. And, we like to say that we're all hiding in plain sight, for example. There's many people around who you would never guess had childhood and adolescent cancer. And that's what actually is fantastic. That's what you really want to be. On the other hand, it does mean that these effects can be invisible and it can be hard to get help when you need it. So what does cancer in Australia look like? We know that, each year in Australia, and this was in 2022, there were 162,000 cases of cancer diagnosed in Australia, but there was a chance of greater than 70% for all patients of surviving at least 5 years. And then the number of people in Australia, and these are Australian statistics, at the end of 2016, and this data lags behind a bit, who were diagnosed in the 5 years from 2013 to 2017. So in those 5 years, there were nearly 500,000 people living with cancer in Australia or had cancer in Australia just from being diagnosed in those 5 years. The statistics in Australia are not as well known or as well studied as they are in the USA, but we certainly know there's well over 1 million people living in Australia at the moment who previously have had a cancer diagnosis. And this doesn't include things like simple skin cancers. These are cancers in which need treatment either with chemo, radio, or surgery. So who are the cancer survivors? We know in Australia at the end of 2017, there were over 120,000 people living who'd been diagnosed with cancer that year. You can see there are nearly 500,000 people in the previous 5 years and 1.2 million people who've been diagnosed with cancer in the previous 36 years. And that was in 2017. So we know that number is much greater now. So all of these people, so well over 1.2, probably up to 1.5 million people in Australia. It's very difficult to know exactly how many, but all of them are at risk of late effects of treatment. And they're anything post a couple of months post cessation of therapy. So some of these can be quite straightforward. So if you've had surgery and you've had a limb removed because of surgery, you've had an amputation, a late effect, of course, is the fact that you've got, you have that amputation and you need to look after the stump and do all of the necessary, or if you have a colostomy bag, for example. But some of them are less visible. So you may have chronic pain or lymphoedema from surgery. The chemotherapy complications can be a lot more difficult to detect, but something that's that we'll touch on is something like cardiomyopathy, or a disease where the heart muscle fails to pump as well, for example. And radiation treatment, again, the late effects can be things like second cancers. The late effects, as I've mentioned, can also be psychological. So PTSD, or post-traumatic stress disease or disorder, is not uncommon, and people having very difficult trouble coming to terms with the fact that they'd had cancer. And a lot of that actually comes up often after people have finished their treatment, when things settle down and people have time to process and deal with a bit more of the psychological effects that occurred from the cancer. And some of them, as I've mentioned earlier, can be quite practical, insurance, employment, along those lines. So how common are late effects? Well, there's really good information here from long-term survivors of childhood cancer. So in the United States, they've got some really good studies where they looked at cohorts of young people who were treated and diagnosed with cancer between the age of 0 and 15. And whilst that's not the age group necessarily we are talking about here today, there are many people who are currently adolescents and young adults who did have cancer when they were younger. And this information gives us really good information about the side effects of treatment. What we know, though, is at the age of 45, 95.5% of cancer survivors who were diagnosed or treated in childhood, so before the age of 15, have some form of chronic health condition. So basically everyone, with a very few exceptions. For those, 80.5 were serious, disabling, or a life-threatening chronic condition. And the risk of the specific conditions really varied according to the exposure. So someone who just had surgery for their cancer treatment is going to be at a lot less risk than someone who had high-dose chemotherapy and radiotherapy, for example. And what you can see there is that incidence, and you're looking here. So if we look at something here, like the first graph just up in the left corner, you can see that the condition is breast cancer. And the treatment that they'd had, it was some form of, so the condition in an adult is breast cancer. This is for people who had radiation that covered the chest or the breast area when they were children. You can see, in fact, that whilst they had treatment below the age of 15, the problems didn't start to occur until after the age of 30. And those problems continued to occur up until the age of around 50 or 55. And you can see with all of those graphs that many of the problems didn't actually become a major issue for many people until many, many years after the initial treatment. What we also know is that these late effects of treatment can dramatically shorten the lifespan of cancer survivors. So we know here, and again, this is looking at USA data, we know that for people in the USA, males and females, those two black lines on the top showing years since diagnosis, and that's what we call age match control. So taking people of the same age and the same gender at the time someone was diagnosed with cancer and following their life expectancy along in parallel with someone who had had cancer. We can see that people who had cancer, unfortunately, despite surviving the cancer, are more likely to die over the next 15 to 25 years of multiple other different causes. However, what's really interesting is even though there are all these statistics, and I think the other thing to bear in mind is a lot of these statistics are based on people who were treated, of course, because we've got data going out 30, 40 years. They were mostly people who were treated in the 80s and 90s, and some of the treatments are quite different now. But even with all of that, we know that even though there's all these statistics about how much more likely people are to have poor general health, mental health, limitations for normal activity, or a functional impairment, which unable to complete all of the things they would like to do. Most evidence actually suggests that survivors of childhood cancer have a perception themselves of being in relatively good health, and only 11% of the members of this group that was studied had said they were in fair or poor general health when they were surveyed. So despite all of these problems, people generally feel that they're doing pretty well. So what's specific about adolescents and young adults in late effect? So as I've already mentioned, the AYA group includes people who were treated in children who by the time they get to adolescence may be actually more than 10 years post their original treatment. Adolescents and young adults are often really caught between paediatric adult centres, and I'm sure in the other seminars that you've had from Lymphoma Australia, you can see that it can be very, very difficult when adolescents and young adults, they really don't fit into either paediatric or adult centres, and it's very difficult to know the right place to access care. The transition from paediatric centre to adult centre is a very hard time. Lots of risk of drop-off, which people not attending clinics, and loss to follow-up. And adult centres are often not as aware of some of the risks that when treatment is given, particularly radiation treatment, is given to tissue that is not mature, the risk of some late effects is much higher. So, for example, if you have irradiation to the breast before the breasts are developed, so essentially before puberty, the risk of breast cancer is much, much higher than if you have radiation to the breast at the age of 18 or 20, for example, when the breasts are mature. There's also, and this really contributes to a lot of people who are children or young adults when they're treated, is that often when you're younger and treated, your parents or someone else takes a large role in the understanding and supervision of your treatment. And obviously that's necessary for people who are very young children, but it depends on the so many different things around the dynamics of the family, the age of the person who is being treated, about the understanding of their primary disease. So there are many people we meet as young adults who really don't have a lot of idea about what their disease exactly was and what treatment they really had, and therefore don't really understand what the long-term side effects might be, because again, they were not educated appropriately at the time. It's that their parents took on that role, and that knowledge has not been dispelled down to the actual patient. And so it leaves people who were actually treated in this sort of knowledge void about their own disease and then what to do going forward, particularly if they were treated when they were quite young. So how do we think about late effects? So we can think about late effects by either the type of treatment that people had, whether it was chemo, radiotherapy, immunotherapy, or surgery, or by the site of the effect. So we think about a system base. So do people have heart effects or effects on the endocrine system, for example? And it really is thinking about them. It needs to be a combination of both these types of thoughts. This is not a table I expect you to necessarily read or understand, but it's an example of what we have at our fingertips when we need to know. So the class of chemotherapy agent, and chemotherapy drugs and these are traditional chemotherapy drugs I'm talking about now, not so much the immunotherapy, but the traditional chemotherapy drugs, as each group of those is associated with quite specific late effects. So one group, the top group there, called anthracyclines, which includes drugs such as daunorubicin, are very commonly used in leukemias and lymphomas. And we know that they're very highly associated with heart problems, particularly something called cardiomyopathy, for example. And so we know that if someone has had that drug, and we know that at certain doses of those drugs, the risk is higher, we can monitor that. And we know that patients who've had those, or people who have had those treatments, need to be monitored at a much closer level from a cardiac point of view as compared to someone who hasn't had those drugs and might have had, for example, what's called an alkylating agent in that next group there, which can lead to problems with the bladder, for example, bleeding and scarring of the bladder, for example, or hearing loss. And so depending on what particular treatment someone has had, we know to target in on potential specific late effects. Whereas there are some late effects that go across all different types of treatment. For example, the risk of second cancers is common across all types of chemotherapy and radiotherapy. So, for example, just taking out ABVD, which is a common treatment which we use for early stage Hodgkin lymphoma, that includes 4 main medications there. So the doxorubicin, which is an anthracycline. The biggest risk is cardiac toxicity. We know that we need to do surveillance testing, and we need to do what we call health promotion, which is about how do people, focus on improving the health specifically for that side effect. We know, for example, bleomycin has lung toxicity, so pulmonary is lung. We know again how to check for that. And the main thing people need to do is to stop or avoid smoking. Again, similar with the vinblastine with neurological problems, and dacarbazine has problems either with the blood or with hormone issues there. So it's just an example of a template that we might use when we're looking at a specific chemotherapy protocol. What drugs are involved? What are the potential late effects? What surveillance could we undertake? And what can people do to not only look out for that, to reduce their risk of complications such as these, for example. So that's just one example of a common chemotherapy regimen. So radiation therapy is not infrequently used for treatment of lymphoma, and in children, it can really, or people who have had the treatment before they've fully developed, so really it's children and adolescents, the radiation therapy can actually affect normal growth and development. So The toxicity or the long-term effects of treatment really depend a lot with radiation on the age at the time you were given the therapy, the radiation therapy. It also depends on the total dose that you were given, regardless of how old you were. What we call fractionation. So anyone who's had radiotherapy will know that it was often given over many different days, and that's called fractionation. So the number of days that the treatment was given is the number of fractions. People will talk about fractions. So you might have had, 20 gray in 5 fractions, which means 20 gray divided up over 5 different days, often consecutive days. But it also depends on what region was treated. So some organs are very sensitive. So for example, breast tissue is very sensitive to radiation damage, and bowel tissue, for example, whereas other tissues much less so. As radiation therapy has improved over the years, radiation therapy is now much, much more targeted. So the amount of normal tissue that's treated, sort of what we might call collateral damage or damage of the tissue, normal tissue around the tumour area or the area that's being treated, is a lot less than it used to be. And that's important too, because normal tissue can be damaged just as much as the area where the cancer is. And also, if there's chemotherapy given at the same time as radiotherapy, it can actually make it more likely to cause problems. Also, some people have underlying genetic problems that make them more prone to problems with radiotherapy. They should be known before radiotherapy and discussed at the time as a matter of consent at the time of radiation therapy, because that would be important to know that someone was at increased risk. These are relatively rare. But again, looking here at this table as a way to look at how we look at the impact of mediastinal radiotherapy. So mediastinum is the central chest area, a common area that we might give radiotherapy if someone had bulky disease for a lymphoma. There might be potential impact to breast tissue, to lung tissue, to the heart and to the thyroid, the organ just at the bottom of the neck there. And therefore the risk there, as you can see, might be breast cancer, lung problems, heart problems, and then problems with the thyroid. And again, what we can do to look for that surveillance and how people can help themselves with promotion of their own health. So, looking at breast self-examination for early pickup of breast cancers, avoiding smoking, looking after your weight, diet, exercise, and having awareness of the thyroid problems, so that having regular testing and reporting any abnormalities that are found. So whilst we look at all of these things according to the individual treatment that was given, it's really important that when we're talking to a patient or a person who's previously had cancer treatment, that we take a much more systematic approach, because as you can already see, we saw that chemotherapy might be causing heart problems, but so can the radiotherapy, and there's no point is going over one thing step by step with each treatment. It's about formulating a plan according to incorporating all of the treatment that someone might have had, and all of the problems to date, and moving forward with that. And so we use what we call a systems methodology. So we work according to the body system from top to toe, and really work also with a system that involves not only the patient at the centre, but the specialist, the GP, supports within the community. So, for example, Lymphoma Australia, and cancer survivorship nurses and cancer survivorship care clinics. The GP is really integral to this process. And as young people, often you may not have a GP, or your GP might be your parents' GP, but it is really important to have your own GP. If that's your parents' GP still, that's absolutely fine, as long as it's someone you feel you can trust and you can talk to. And that GP is very unlikely to be the GP you still have in 10, 20 or 30 years as people move around. So it is also really important that you have a care plan that's formulated at the end of treatment and discussed with you, and that includes a summary of the treatment that you've had, what the planned follow-up is, what the referral, if it's required, to late effects service, which generally, if someone's had chemotherapy and radiotherapy, is recommended. If it was just chemotherapy, then less so. And then what's the plan for future risks? What's the plan for prevention? And what is the monitoring strategy going ahead? So that not only is the GP and the specialist aware of this, but the patient is the central person who is in charge and control and has ownership of their late effects and survivorship care plan. So again, not expecting to go over this in detail, but just to show some of the things that we might be thinking about or looking at when someone comes to a late effects clinic or we're talking about late effects. There's, radiation versus chemotherapy toxicity that really can range from, as we were saying, top to toe with multiple different complications. And so it's really important that we're doing what we can to try and monitor and prevent any of these complications occurring. So looking through some of these and really just to talk through as examples of what might be a problem, is that there's problems with the central nervous system can range from problems with memory, and many people talk about chemo brain or just having trouble with their memory. Even fatigue can cause problems with not being able to remember as well. Some people had treatment, certainly at a younger age, might have educational problems, either from missing a lot of school or from having problems with, again, with memory or being able to process different what we call executive functions or higher level functions in the brain. People might have had strokes or bleeds in the brain as a complication of treatment as well, or spinal cord injury, for example. The other problem that can happen is problems with the eyes. So something called cataracts, which are common in older people, can occur at young ages if people have had radiation that can affect or be near the eye, for example. And that's important that it's monitored and treated early if it becomes a problem. Interestingly, we do sometimes see problems with the what we call musculoskeletal. So one problem we can see is something called osteoporosis, which is soft bones. Again, a problem that is much more common in older people who haven't had cancer type treatments. But we see this particularly in radiation fields. We also see people having short stature if they were treated before they'd had full puberty as well. And it's a bit hard to see in these pictures, but you can almost imagine that you see the shoulders on both of these young people, that they're asymmetrical. And if you had radiation to one half of the body but not the other, because that's obviously the side where the cancer was, that half will not grow the same as the other. And you can result in long-term problems where the body is not symmetrical or not balanced on both sides. And that can cause multiple different problems going forward. So one of the biggest issues that we see are what we call endocrine dysfunction. So the endocrine organs are the ones that make the hormones, and these hormones do all sorts of things in our body, including helping us to grow, helping our energy levels with our thyroid, helping our fertility. So FSH and LH are girl fertility hormones, testosterone's the main boy one, and or male one, I should say, male and female. And all sorts of difficult issues can occur, from growth delay or growth slow growth, retardation, thyroid problems, so hypothyroidism. Premature menopause is not uncommon after chemotherapy and different types of chemotherapy, or reduced fertility or infertility. And then you can also have a disease called diabetes insipidus, which, unlike diabetes mellitus, which is the typical diabetes you see out there, comes from a problem with the pituitary gland in sort of the middle of the brain there. Also, thyroid damage is not uncommon, and the thyroid not working properly, which can lead to weight gain and low energy levels. And again, most of these can be treated to some degree, but the earlier they're picked up and monitored for, the earlier we can intervene. Metabolic syndrome is a very common complication of long-term, in the long term from cancer treatment. And it's particularly associated with treatment of cancers at young age. So not just childhood, but adolescence and young adulthood. It's associated also with people who've had cranial radiation therapy, so brain radiation therapy, and whole body radiation therapy. But people who've had chemotherapy alone are also at increased risk of metabolic syndrome. Metabolic syndrome is this combination of high blood pressure, heart disease, high blood pressure, high cholesterol, diabetes, and being overweight, so obesity. And it really does cause a lot of, and puts people at risk of a lot of complications, from cancers to ovarian problems to dementia, to NAFLD is a non-alcoholic fatty liver disease, which insulin resistance, or diabetes itself, And all of those problems can lead to premature death from strokes and heart attacks. And this is the primary thing that you hear people talk about when, they're in their 50s or 60s. Yet metabolic syndrome can happen to people in their 20s or 30s when they've had treatment for childhood cancer. And it's particularly important to be aware of it and get onto any signs of any problems early. It's also important for GPs, because if you go to your GP and you're 25 years old or 30 years old, your GP is not going to be immediately thinking, oh, I must check their cholesterol and their blood pressure, because it's not something you would routinely do on a 25 or 30-year-old. Yet if you're 50 or 60 and go into the GP, then that's absolutely the first thing they do. So it's about making the primary healthcare practitioners, usually the GPs, aware that some of these problems that normally would occur in someone older are going to be occurring younger in someone who's had prior cancer treatment, just so that they're looked for, because again, anything that's picked up early can be managed. Heart disease is something we do worry about, and particularly because of these drugs called anthracyclines, adriamycin or daunorubicin being the two most common ones. And these are related to the dose of the drug that people had and can cause problems with cardiomyopathy, which is how the heart pumps. But any treatment to the heart, including radiotherapy that involves the chest and can affect the heart, can also cause coronary artery disease, which is heart attacks, pericarditis, which is an inflammation around the heart, and valvular disease. So the heart valves, which normally pump up and down, don't pump as well. There can also be problems with what we call conduction system, which is the electrical wiring of the heart, where the heart loses the ability to send those signals for the heartbeats so regularly, and you can end up with problems with irregular heartbeats, for example. Equally, if you've had radiation to the neck, it can affect some of the big vessels in the neck, and they need to be monitored and checked as well. So all of those things are really important. We find also that kidneys and the genitourinary system are important. So kidneys are particularly vulnerable to a number of chemotherapy agents, the cisplatin, and methotrexate, which often cause problems with the kidneys at the time they're given. So not so much a late effect, but an effect at the time. But if there are problems at the time, they can go on to cause problems in the long term as well. We see that radiotherapy to the kidneys can result in significant problems, and often surgery can disrupt or disturb around the area where the kidneys were. So it's important that if people have had surgery in those areas, that they know what the effects specifically are of that surgery. Lungs are very sensitive as well to both chemotherapy and radiotherapy. A drug called bleomycin in particular, which is used commonly for Hodgkin lymphoma, can cause problems with the lungs. And for this reason, that modern therapies for Hodgkin lymphoma are trying to eliminate the use of bleomycin completely, or only give 2 cycles as compared to the normal 6 that we used to give sort of 5 or 10 years ago. So removing that, but again, causes problems with basically infiltrates in the lungs. So lungs, these areas are meant to be black, but they're all looking a bit white, and can also cause problems there with fluid in the lungs sometimes too, and fibrosis, scarring of the lungs. The other problem, particularly with radiotherapy, is radiotherapy can cause problems where the walls of the lungs don't look normal. So if you can see on the bottom X-ray there, that one side of the lungs here on the right side of the lungs looks really big and full of black air, whereas the other side's all kind of squished in. And that's because that left side had radiotherapy and can't expand and contract as normal. It's what we call restricted or a restrictive deficit. And so that means that the lungs can't fill up with air normally. And that person is going to have less ability to for example, when they exercise, have less ability to not feel short of breath or feel more short of breath and struggle for air a bit more with that going forward. So the gut problems with the gut can occur mostly from, and we all know the gut can be trouble when you're actually having chemotherapy, but in the long term, most of the problems relate to either surgery or radiotherapy. There's not many problems of the gut resulting from chemotherapy, long-term problems for the gut. But if people had surgery or radiotherapy, they can get what's called adhesions, which is a fibrotic band that blocks bits of bowels. And you can see in the X-ray here that there's a bit of bowel there that's all sort of come down to a very narrow point in the middle there. And that's a blockage of the bowel resulting from, again, one of these adhesions. People can have malabsorption. and they can have fistulas. Fistulas are where there's an abnormal pathway through from an area of tissue, for example, the gut, either to the outside or through to another organ, and they can cause problems in the long term, but they're from surgery and from radiotherapy. The reproductive organs can be very affected at different times from chemotherapy and radiotherapy, particularly the alkylating agents, or radiotherapy to the ovaries. And we know that there's doses of radiotherapy that destroy. So one of the differences between men and women is that in women, the ovaries contain all of the eggs from the time a girl is born. And so no matter what treatment a person has, chemotherapy or radiotherapy, those eggs are exposed to that treatment from the time a child is born, from at any stage. Whereas for men, sperm are produced constantly. And so the sperm today were not exposed to the treatment that was done, last week or, years before. So women are particularly sensitive to long-term problems with fertility from treatment, more so than men. And not only from the eggs, but also if there was any damage to the uterus, because if the uterus is therefore unable to hold a baby or unable to support a pregnancy, that can also result in long-term problems with having children in the future. So something that we all worry about a lot is the chance of getting another cancer. And we know, unfortunately, and again, bear in mind, this is data, we've got 30-year-old data. So this is from people treated for cancer in the 1980s, mostly 80s and 90s. But we know from that data that within 30 years, around 20%, so 1 in 5 people had had a second cancer of some sort. When you excluded the non-melanoma skin cancers, so included melanomas, but excluded the other skin cancers, that came down to 7.9%. So quite a lot less, but still quite significant. The other types of tumours people can have, the ones that are non-malignant, or they're not a cancer, but they're still a tumour, and 9.1% of people had a tumour that wasn't a cancer, and 3.1% of people had a meningioma, which is the most common non-malignant cancer that we see. A meningioma is a form of brain tumour. And whilst it's not a cancerous tumour, it can be quite significant, because a brain tumour can be in a space that causes problems with all sorts of functions in the brain, and it can be fatal if not treated or removed. So you can see that this is a 6 times increased risk of getting another cancer amongst a cancer survivor compared to someone who's the same age, same gender, doing all the same things, so non-smoker, all those sort of things matched. So we know that certainly is a big risk. And we know that when in Australia, there were around 31,000 people who were diagnosed with cancer between the age of 15 to 24. Since 1984, over 1,000 second cancers had been diagnosed in that group. And that was just recent data, looking at the last 30 or so years. So particularly a group that's been highly studied, and one of the good reasons people with Hodgkin lymphoma have been highly studied is that we have a large number of survivors of Hodgkin's lymphoma, which is fantastic. But we do know that they're at high risk of secondary malignancy. And again, this is from treatment given back, 20, 30, and here you've got data going out to 40 years. You can see that that's the biggest risk factor for patients who'd had treatment back in the 80s for Hodgkin lymphoma was a secondary malignancy, going up to around 30% at the 40-year mark there. At 30 years, 19%. If people were less than 21 years old at the time they had treatment, that risk was higher. And that's because of the underdeveloped tissues being exposed largely to radiotherapy. These cancers that people are getting were breast cancers, thyroid cancers, sarcomas, colorectal cancers, lung and gastric, so rather varied. But what we didn't see were a lot of Hodgkin lymphoma relapses. There were some, but not many. So this is an example of a radiation-induced meningioma, this CT scan here of the brain tumour. And radiation-induced meningiomas are common. They typically occur at about 20 years after you had the radiotherapy, and it occurs when you had radiation therapy to the brain. So if you had radiation therapy to the chest or lung, you're not at increased risk of getting a meningioma. Problems with thyroid cancer, skin cancers, breast, colorectal, and sarcoma are all generally related when people have had radiation therapy to that direct area. Whereas if people have had radiation therapy to a different area, you're not at increased risk. It's chemotherapy that puts people at risk of blood problems, and they are particularly myelodysplastic syndrome and AML, or acute myeloid leukemia. So MDS and AML are related to the type of treatment that people had. A drug called alkylators with cyclophosphamide that's often used as, for example, it's used in CHOP chemotherapy, and particularly at higher doses. And they typically occur, these problems occur at 5 to 6 years after people have had their original treatment or original chemotherapy. We know also that these other drugs called topoisomerase 2 inhibitors, again, a drug called etoposide that again is used in lymphoma. People can get at increased risk of acute leukemia, but these occur within 12 months to around 3 years after the original treatment. So what should every survivor know? So it's really important to have an understanding, or to have written down somewhere, what kind of cancer did I have? What type of chemotherapy did I have? What kind, how much of radiation did I have, and where was that radiation if it was given? What kind of late effects am I at risk of? What can I do to make a difference? And who can I contact? Where can I go for more information? And those questions are the ones that people really, as a survivor, should have, even if it's not something that people want to look at every day. It's important to have down somewhere. So ideally, every person who finishes their cancer treatment in Australia should be able to access a survivorship care plan. And a survivorship care plan, and this is just one example of one, I've got here about a bit more detail about them, and they're available from the Australian Cancer Survivorship Centre, but should be provided by your haematologist, oncologist, nurse practitioner, whoever is coordinating your care, around a summary of that information around what the treatment was that you received, what the cancer was that you received treatment for, what the plan is for follow-up for care, what lists of tests you should have and when, what were the goals of follow-up, what other things to look out for, what to be alert for, what to do if you find anything that you're worried about. And then to finish with a wellness plan. So the wellness section focusing on things you can do to look after yourself. And again, that should be tailored to your specific needs. So good advice is generally things like a healthy diet, exercise, please not smoking, please, and avoiding secondhand smoke, and limiting alcohol and sun exposure, being sensible about alcohol and sun exposure. Other things about health changes depending on specific risks that you might have. For example, if you have heart risk, it might be that, watching your blood pressure particularly carefully might be something that you might be able to do, for example. But also included in this should be advice about coping with emotions related to the cancer experience, advice about community-based services, and also advice about screening programs. For example, breast screen. So when people are the age of 45 or above, we recommend that they move their breast screening into the breast screen program that's available free of charge all around Australia. So in summary, we know that around 1 in 25 Australians is actually a survivor of cancer, and that late effect surveillance and prevention is a really crucial part of management, because many of these side effects can be managed and can be, the risk can be changed significantly if we're proactive in not only looking after ourselves, but also in picking up any of these effects early. Some of the effects are actually quite treatment specific. So that's why it's really important to understand what treatment that you had in particular, and so that you know exactly what problems that might be relevant and to look out for. Whereas other risks, for example, some like the myelodysplastic syndrome are related to generally any type of chemotherapy that was had, or metabolic syndrome, for example. Generally, the younger the age you were when you had treatment generally relates to a higher risk of late effects. However, all of that is improving significantly as treatments improve, and also now a lot of the treatment for primary cancer considers minimization of late effects as the goal of any primary treatment. So the first thing now that we're thinking about when we have someone, particularly a young person, at a point of diagnosis of their cancer is we're starting to think about very much not only, of course, we want to cure this cancer, but the second thing we want to do is we want to minimize the long-term side effects. So, for example, the treatment for Hodgkin's lymphoma, we no longer use bleomycin as much or if at all as we used to, because we know that a lot of the treatments like immunotherapy, a lot of the newer treatments have a lot less long-term effects. On the other hand, we also don't have a lot of long-term data for these treatments because many of them are very, very new. But we know through their mechanism of action that it's very unlikely that they're going to cause the sorts of long-term side effects that we see in many of the traditional chemotherapies that I've talked about today. So thank you very much for your attention, and I'm very happy to take any questions.
Thank you, Kylie. There was a lot of information.
A lot of
to go
information,
through.
I know.
A lot of information, and it's wonderful, because I think a lot of people aren't quite aware of all of these things that can go on. So please don't feel overwhelmed by all of those possible. They're all possible.
They're all possible.
Things. That's right. They're not probable. They're probably more possible, but it's good to know. And it's just to be aware when you're going and speaking to your GP that, hey, you've had treatment previously. This may be something that's contributing to what's happening. I have a couple of questions for you. If a patient has not been given one of these survivorship plans by their doctors, I mean, this is only, I must say, a relatively new thing. I mean, I know we've probably been talking about survivorship for quite a long time. I've been nursing a long time, but really it's only sort of coming through right now-ish.
Yeah.
Is there somewhere they can access? I mean, I know the survivorship centre, they can go and grab one. Is it something they can just get on the website that they can download?
Yeah, so you can certainly download the template for a plan, but your specific info, and it depends how much specific information you actually have about your own disease and your own treatment, so that a lot of that detail your GP might actually have some of that information. But the other thing is your GP can refer you to a cancer survivorship clinic, either the Cancer Survivorship Centre, or in your state there are various cancer late effects clinics who can also help to fill a care plan in for you. The other thing is to also contact the centre where you were originally treated, and they can often also provide you with a care plan. And I know we're doing that retrospectively for some people. We've been using these plans for about 5 or more years. So they're sort of more common. And I think it depends very much on the different centres, how active they have been in giving out these types of care plans.
Right. You just answered my other question, which was, can you fill it out retrospectively? Because I know that there are, like a lot of people who may be joining us that had treatment 5-10 years ago, and they're still looking for, what am I supposed to be following up nowadays? And I suppose it does highlight the importance of having a good GP that you see, rather than just trying to find any GP from here or there. I know it's hard to get into them right now, but yeah, it's good to have one that you can have, or if not, then have a really good plan that when you're going to them and speaking to them, you can lay it all out for them. This is what's happened. This is the treatment I've had. These are what I think might be happening. And can we investigate that?
Absolutely. Absolutely. And yes, there's obviously lots of potential late effects, but as we know, many people have none or very few late effects. And I think the other thing emphasising is that all of the data is really old, or comes from people who were treated a long time ago, because that's to get 30 to 40-year-old data. They obviously have to be treated 30 to 40 years ago. And we know that cancer treatments have changed enormously in that time. And we know that the rates of complications and second cancers are going to be a lot less for people treated in the last 5 to 10 years as compared to people who were treated, in the 1980s, for example.
Yeah, beautiful. Yeah, and it is important to know that, because I mean, the treatments are so different to what we used to give a long time ago. There's a couple of questions here. So I'm just looking at my other screen. So this is from Brendan. So regarding health promotion and doxorubicin, what does weight, diet, exercise mean? I.e., maintaining healthy BMI or low impact exercise?
Yeah, so weight, diet, exercise basically means maintaining a healthy weight, a healthy diet, which is a balanced diet. Doesn't mean you can't have Tim Tams and chocolate. It just means don't make them your primary food group, except maybe on your birthday or something, And exercise doesn't necessarily mean low impact exercise. It means just keeping active. And that looks different for everybody. So if you're a a young man, that might look like, footy games and, hanging out with your friends, or I don't know, rope climbing, abseiling, all sorts of things you might want to do. If you're an older person, that might look like going for a walk every day, for example. It will vary enormously, but keeping generally physically fit and active, nothing that isn't good general health advice for everybody in the community, but just more so when you've had previous treatment, because you're at slightly higher risk of complications.
And I always say patients, even I think post, can still access exercise physiologists. I know you only get a couple of subsidized sessions, but it's better than nothing. It's getting on that right path, getting in that right direction so that you know what you need to be doing. And it's all about just working with either a good personal trainer or a good physio to try and figure out. It's always good to have a little bit of muscle mass all the time. So that's something that I always try and recommend. And I think there are programs out there too for this year. I know, and Canteen used to run one that was for under 24-year-olds. Yes. I don't know if there's that older bracket. Sometimes the other groups, so, if you have breast, I know that the breast nurses run certain fitness groups, those types of things. But obviously being lymphoma, I wish we could have one. I'd love to have one, and it's something I'll work on forever. But yeah, it's try and access them in your local area if you can. Even local councils run some type of fitness activities for free. So it's just definitely something to look at. I know it's hard, but it's one thing to try and get back into. It will keep you feeling much better.
Yes.
The other one is going on to cardiomyopathy risk. So I heard that there have been studies showing elevated cardiomyopathy risk to young adults with the Pfizer-Moderna vaccine. Is there elevated risk for Hodgkin lymphoma patients who have had anthracyclines and the COVID vaccine? It's a good question.
Yeah, not related at all. So yes, there is a with the Pfizer vaccines, there was a small risk of, again, very small, but very well publicized risk of some cardiac side effects. And it was not so much cardiomyopathy, but a pericarditis, which is an inflammation of the heart, rather than cardiomyopathy, which is where the heart muscle doesn't pump as well. But no, that's completely independent to people who've had lymphoma before. So there's no reason why anyone who's had not just Hodgkin lymphoma, but anyone who's had anthracyclines, they're commonly used to treat almost all types of, many types of lymphoma, but also leukemias and lots of other cancers. There's no reason to avoid vaccination for that reason at all. No, not associated, and doesn't put people at increased risk. And in fact, we'd always encourage people to have COVID vaccines, because particularly, we all know that, after you've had chemo, that you're just more likely to get your immune systems run down, and you're more likely to pick up colds and flus and everything like that. And at a higher risk of complications of COVID, of the disease COVID, not the vaccine though. So definitely would recommend vaccines, and no increased risk of heart complications.
And in saying that, I probably too, in this point in time, should be recommending you go and get your flu vax. This is going to be a really terrible flu season. And, as you're still going to be, sometimes you're still lower, what am I trying to say?
More immune system.
Immunity. Yeah. So flu vax is definitely recommended. I think it's something that we're not going to be able to avoid this season, and we're already seeing it. So
yeah, it's already bad in Melbourne. Yeah.
Very bad in Brisbane. So I think the numbers have almost quadrupled in the last month. So yeah, anyway, that's back another story. But yeah, I really do. I don't think there was any more questions, and I think you've actually answered all of my questions. So I really appreciate, Kylie, the time that you've spent going through this with the patients. And I know there probably might be some questions afterwards. So if there is, we do have our lymphoma nurse line. It's a 1-800-953-081. But if you need to be able to contact us, you can either email us as well. So we can, if it was something specific to Dr. Kylie Mason, we can also get onto her and ask her as well. So yeah.
And look, I encourage you also, if you've got questions, to touch base with your GP, or touch base with your local centre that you were treated at, or if you were treated remote, somewhere else, with the local centre. And again, there are care plans for non-Hodgkin's. There are care plans. I could say non-Hodgkin's is just one of the examples. The care plans should be made for each individual patients, but there are care plans for non-Hodgkin's as an example on the Cancer Survivorship website. Yeah. Just sorry, answering one of the questions that just came up.
Yeah, that's okay. I've just seen that come through too. Yeah, I think it's really just a template, isn't it? And you're supposed to take that and fill it out.
Yeah, and the doctor would fill it out. So or the doctor has that and fills it out. So there's one for non-Hodgkin's as an example, but no, they're meant to be filled out individually. Even the example, it's a good start, but it should be done individually because everyone has slightly different treatment and slightly different risk factors. But yeah, so even more so to touch base with your, yeah, exactly. Yeah. No, only has a few cancer types because it's a template. Yes.
Yeah. So it's not one, there's not actually one that's made specifically for Hodgkin's. You need to work that out with your practitioner as to what you have, and then what actual treatments you've had, and then what follow-up you need to be having. So you need to be printing that and taking it to the doctor for them to help fill out together.
Yeah,
no worries, Jo.
No two Hodgkin patients were treated exactly the same. Yeah, there's lots of different ways it can go. So
that's also interesting to remember too, if you were still in contact with people who had treatment with you and they were very similar, if they were to get something, it doesn't mean that you're also going to get it as well. So that's the hard part to remember.
Yeah, and then also remember there are late effects clinics in most major metropolitan cities. There are late effects clinics that your GP or other people can refer you to. So if you've got doubts, concerns, worries, absolutely make contact with a late effects clinic, and they can sit down with you, go through the risks, do a care plan. That's particularly good if you were treated overseas or interstate. You haven't got any way of finding out what you actually had, and often the late effects clinic can sit down with you and nut out what was likely to have happened and work out a care plan from that.
And do you know if they're available to do those sorts of things online? So for people who are in those rural areas and can't make it to an actual centre, are they available to do
they have
online?
Telehealth. Yeah, they have telehealth clinics. Yep.
Excellent.
Yep. So all good.
Love anything that people can access from the bush.
Yep, absolutely. Always telehealth. Yep.
Frank's just asked if we'll get the whole webinar. I will send the recording. It'll come out in email and also be uploaded to Spotify later as well. So it'll go YouTube and Spotify. There you go. Anyway, I don't think there's any more coming through. It's good that Jo's been able to get on and have a look and actually find it. So I probably should put the link up. I might send the link once, when I send the link for the webinar out, I'll pop the link to the actual survivorship template as well. So I'll do that for everyone.
There's lots of good information on the Australian Survivorship Centre generally about health and wellbeing after cancer too. So it can be helpful.
Beautiful. Thank you very much. I really appreciate your time today, Kylie. And I know everyone else does too. So thank you for all of that information. There was lots to take in.
There was.
But we loved it.
Okay. Thanks, Lisa.
Beautiful. Thank you so much. Thanks, everyone.